Thyroid neoplasms. Thyroid neoplasms or thyroid tumors is an important topic in general surgery. It's important not just for the doctors and the trainees, but also for the medical students who are preparing for their exams. It is an important subject for clinical examination as well as theory examinations for the undergraduates. In this short overview, I shall touch on some of the clinical signs and symptoms of thyroid tumors, the investigations, and some basic treatment, medical and surgical, of these tumors of the thyroid gland. The thyroid gland is located in the anterior aspect of the neck. Each consists of a right and left lobe. Okay, the two lobes joined together by the isthmus in the center. Okay, it extends from the thyroid cartilage above to the tracheal ring 5th and 6th ring below. And this isthmus overlies the 2nd to the 4th tracheal rings. And in some patients, there is an additional lobe known as the pyramidal lobe, medially in the middle. Okay. This thyroid gland is closely related to a number of structures, which is really important for the surgeon. Posteriorly, there are the parathyroids, superior parathyroids related to the posterior surface of the upper lobes, and the inferior parathyroid related to the lower lobes of the thyroid gland. See, these are important because during thyroidectomy, this must be identified and spared to avoid hypoparathyroidism. The other important structure which is related to the lower lobe of the thyroid is the recurrent laryngeal nerve, which is a branch of the vagus nerve which enters posteriorly behind the thyroid into the tracheoesophageal groove, where it goes into the larynx. So these two nerves are at risk of being damaged on removing the thyroid gland during surgery. They must be carefully looked for, identified, and preserved. A section of the thyroid gland will reveal numerous follicles. Okay, the whole thyroid is made of numerous follicles, and these follicles contain a substance known as the colloid, colloid-filled follicles. And each of these follicles are lined by a single layer of cells known as the follicular cells. And in between these cells, follicular cells, scattered among them are larger cells known as C cells or clear cells, which produce calcitonin. Okay, this is a close-up view of a single follicle here. It consists of a single layer of cells known as follicular cells, and the center is filled with colloid. Okay, and scattered among them are larger cells known as the C cells or the parafollicular cells, which secrete calcitonin. The parafollicular cells are the origin for the medullary carcinoma of the thyroid, whereas the more common papillary and follicular carcinomas arise from these follicular cells that line the follicles. Okay. This table is an elaborate classification of malignant thyroid neoplasms. Basically, there are 4 types of carcinomas in the thyroid. First, the most common is papillary carcinomas, followed by follicular carcinomas, and the Hurtle cell carcinomas is an aggressive variant of the follicular carcinoma. Then an anaplastic carcinoma, lastly medullary carcinoma from the C cells of the thyroid. Papillary and follicular are considered differentiated carcinomas. DCT, differentiated carcinoma of the thyroid. Then there are a large group of others, miscellaneous, which can occasionally occur in the thyroid, but by and large, they're very rare. Among the most common among them is the lymphomas, which is a generalized disease involving the thyroid as well. From the practical point of view, this classification is simpler and more useful. Okay, the follicular cell origin will be the differentiated carcinoma, papillary, follicular, and Hürthle cell carcinoma. The undifferentiated variety is the anaplastic carcinoma. And then originating from the parafollicular C cells is the medullary carcinoma. Okay, these are the 4 primary carcinomas of the thyroid which are most common. As you can see from here, the follicular carcinoma occupies about constitutes about 80% of all the primary tumors of the thyroid, followed by 10% follicular, 3 to 5% Hürthle cell carcinoma. The undifferentiated constitutes only about 1 to 2%, and the medullary carcinoma about 5%. Next, we come to the clinical features of the thyroid tumors. First, the symptoms. The majority of patients come complaining of swelling or a lump in the neck, either in the front of the leg or by the side of the neck. So it is utmost for us to get the details of the swelling or the lump. Okay, its origin, onset, progress, whether it's associated with pain. These are all important parameters that we must look for. Then the pressure symptoms due to the swelling or the lump, which is 3 of them: hoarseness of the voice due to pressure on the recurrent laryngeal nerve, dysphagia due to pressure on the esophagus, and stridor, which is a late symptom due to pressure on the trachea, which the thyroid lobes straddle. Hypo and hyperfunction symptoms are rarely encountered in malignant lesions of the thyroid. As for the signs, again, a lump is the most commonly noted sign, which is usually a solitary nodule. Occasionally, there can be more than a nodule. Again, as in the history, it is important to determine the certain features of this lump which will suggest it is malignant. The mobility and the fixity of this lump. Malignant lesions can tend to be fixed, whether it moves with swallowing. The consistency, malignant nodules tend to be hard, and also the associated lymph nodes in malignant nodules. Next, investigations to be done for thyroid cancers. First, thyroid function test, which includes T3, T4, and TSH. This, in malignant lesions, most of the time, majority of malignant cases, they will be normal, within normal limits. Then, thyroglobulin can be assessed. The serum level of thyroglobulin is a good serum marker, especially for monitoring the patient after surgery. Ultrasound scan of the thyroid is very, very useful in diagnosing early lumps which may be malignant. Next is the fine needle aspiration cytology, or FNAC, which has become very essential and compulsory in most cases for making a diagnosis whether it is malignant or otherwise. And CT scan can be occasionally used, especially in anaplastic cancers, which tend to be very aggressive and invasive locally. So these can be useful to detect the operability of the patient with anaplastic cancers. This slide shows you the methods of diagnosing a malignant lesion in the thyroid. Of course, the first of all is clinical, the history and physical examination of the thyroid gland, followed by ultrasound scan of the thyroid function test T3, T4 and TSH. And at times you may want to do a thyroid scan, radioisotope thyroid scan, to see whether the nodule or the lump that you notice is hot or cold. And then the fine needle aspiration, which has become the most important investigation to rule out malignancies in the thyroid. This thyroid sequencing testing is another genetic testing which is used nowadays, but its usefulness is still controversial and it is costly. So for practical purposes, the thorough clinical examination with the thyroid function test, ultrasound scan and fine needle aspiration will suffice in most cases of thyroid lumps. The staging of thyroid cancers by the TNM criteria is a very good classification. Okay. Stage 1 refers to less than 2 cm in diameter. The tumor is less than 2 centimeters in diameter without evidence of disease outside the thyroid glands. That means less than 2 centimeters confined within the thyroid gland. Stage 2, tumor is 2 to 4 centimeters, again without evidence of extrathyroidal disease. Stage 3, the tumor is greater than 4 centimeters or level 6 nodal metastasis or microscopic extrathyroidal invasion regardless of tumor size. And stage 4, any distant metastasis or lymph node involvement outside the level 6 or gross soft tissue extension. Okay, characteristics of papillary thyroid carcinoma. Okay, this is a differentiated carcinoma. The peak onset ages are between 30 and 50 years old. Papillary thyroid cancer is the most common cancer in the thyroid and is more common in females than in males, the ratio being 3:1. The prognosis of the disease is directly related to the tumor size. Less than 1.5 centimeters is a good sign of prognosis, good prognostic sign. This cancer accounts for about 85% of thyroid cancers, and it is directly related to exposure to radiation. More than 50% of the cases, it spreads to lymph nodes of the neck. Distant metastasis to the lungs and bones is uncommon. The tumor is considered as slow growing and the overall cure rate is very high, nearly 100% for small lesions in the young patients. Next, the follicular carcinoma of the thyroid. This is the second most common, constituting about 10 to 15% of all thyroid cancers. Often, it is difficult to distinguish from benign follicular neoplasms on FNAC. The lymph node spread is uncommon only about 8 to 13% of cases spread for lymph nodes. Typically, its spread is by hematogenously, with distant metastasis typically to the lung and bones in about 10 to 15% of cases. The variant Hürthle cell carcinoma is more aggressive, higher rate of lymph node metastasis than the classical follicular thyroid cancer. Rarely presents with distant metastasis, however, highest incidence of late distant metastasis occurs. The third type of cancer is the anaplastic thyroid carcinoma, ATC, or undifferentiated carcinoma. Okay, it constitutes about 3% of thyroid cancers, in fact less than 3%. Most aggressive of all the thyroid cancers with the poorest prognosis. Uncapsulated usually. Extension outside the gland is common. Death in several months due to airway obstruction, vascular invasion, and distant metastasis. Higher incidence in pre-existing multinodular goiter. It is, fortunately, a very rare tumor. The last of the 4 common cancers of the thyroid is the medullary carcinoma of the thyroid, MTC. This arises from the calcitonin-producing parafollicular C cells located in the thyroid. It accounts for 2 to 5% of thyroid cancers. And there is a heritable possibility in about 25 of cases due to mutations of the RET gene, which causes the familial MTC, which is related to the multiple endocrine neoplasia 2 or MEN2. The treatment of thyroid cancers is basically surgical, and this involves thyroidectomy, which can be either total thyroidectomy, subtotal thyroidectomy, or total lobectomy. The second aspect of treatment is the TSA suppression by thyroxine. This is especially used for patients post-thyroidectomy patients. And the third one that is commonly used and is becoming increasingly used is radioiodine ablation of the thyroid, and this is mainly used for recurrence of thyroid cancers. In this respect, the serum marker thyroglobulin is a very important aspect of follow-up of the patients after the operation. Any increase in thyroglobulin level may be an indication of recurrence of thyroid cancers. The standard initial treatment of thyroid cancer is shown in this diagram. First, total thyroidectomy is done to remove the thyroid with all the cancerous tissue. This is then followed with radioactive iodine treatment to ablate all the microscopic residual thyroid tissue that may be left behind. This ablation will then leave the patient without any functional thyroid tissue in him, and he becomes completely dependent on exogenous levothyroxine. So it is important for this patient to be started on thyroxine replacement therapy for the rest of his life. The surgical treatment of thyroid cancers. Initially, thyroid cancers require total thyroidectomy with central neck node dissection. May consider hemithyroidectomy if a single focus of papillary cancer within the lobe measuring less than 1 cm. These are nowadays classified as low-risk tumors, the size basing on the size. So for them, you can do a hemithyroidectomy or lobectomy. More extensive resection for patients with evidence of invasion of neck structures may have to be carried out. Surgical risk of extensive treatment, especially total thyroidectomy, include hypoparathyroidism and recurrent laryngeal nerve damage. And they usually require longer stay in the hospital after surgery to monitor the calcium levels. Okay, this is a diagram to show the lymph nodes in the neck where the surgery for the thyroid takes place. Okay, this compartment, the medial or the midline compartment here, is known as the visceral space where the thyroid is located. Okay, and the lymph nodes in that region is called the level 6 or the visceral space lymph nodes. So all these lymph nodes, these are the visceral space lymph nodes, which may have to be removed on doing thyroidectomy for cancers. Types of thyroidectomies. What are the thyroidectomies commonly done for thyroid cancer? First is total thyroidectomy, where the complete removal of all visible thyroid tissue is undertaken. Okay, this is quite straightforward. There's no controversy over it. Secondly is the near total thyroidectomy, where there's complete dissection on one side, leaving a remnant of thyroid tissue laterally on the contralateral side. The third type is known as subtotal thyroidectomy, which leaves a rim of thyroid tissue bilaterally in both lobes. And the last one is hemithyroidectomy, in which one lobe with the isthmus is removed. And this is the minimal operation for the thyroid cancer. And this operation is also known as lobectomy. To make it simpler, I tend to classify the types of thyroid surgery into 3 main types to make it simpler. First is your thyroid lobectomy. It's generally performed when tumor is restricted to one lobe of the thyroid gland and has not yet started invading the other organs or lymph nodes. So you remove the thyroid of the affected lobe with the isthmus. This is lobectomy. Then subtotal thyroidectomy or STT is the procedure when most of the gland is removed, but a small portion is left behind as well. So you see, most of the thyroid, the white part, is removed, leaving behind a thin ring of thyroid tissue on one side. Some people prefer to leave some tissue at the apex on both sides, whereby the parathyroids are spared. And then the third type is total thyroidectomy, which is quite easy. When the entire gland is removed, the procedure is also known as total thyroidectomy. Okay, so this is the entire gland. So this is a simplified version of remembering what the type of thyroidectomies have been used to describe the various procedures. Okay, this diagram shows you the next modality of treatment for thyroid cancer, the radioactive iodine therapy. Iodine therapy specifically targets the thyroid and has very little effect on other parts of the body, as the cells in other tissues rarely take up iodine. So the radioiodine is now taken as a drink or capsule. It is very much easier to take radioiodine these days compared to previously when it has to be given intravenously, higher exposure of radiation. Secondly, radioiodine or radioactive iodine molecules are absorbed through the intestinal tract and goes into the bloodstream, where the thyroid gland absorbs most of the radioiodine into itself. In the process, it destroys itself and the cancer cells. It must be remembered that radiation or radioiodine therapy destroys not only the cancerous cells but the normal thyroid cell as well, because these normal thyroid cells also take up the radioiodine. Okay. After thyroidectomy, especially total thyroidectomy for thyroid cancer, the patient is left without any functioning thyroid tissue. As a result, the level of thyroxine drops drastically. As a result of this drop in thyroxine, the TSH from the anterior pituitary increases. As a result of this increase in TSH, whatever tissue that is left behind, microscopic thyroid tissue that has been left behind, tend to be stimulated and grow, and there's recurrence of the tissue. In order to normalize the TSH, patient has to be given replacement thyroxine therapy, which will not only prevent the symptoms of hyperthyroidism, it will also stop the further release of increased release of TSH to normalize its level. In the case of cancer after thyroidectomy, this release in TSH, the sudden surge of TSH, may stimulate whatever cells, thyroid cells that are existing, cancer cells, to proliferate, and this will result in the recurrence of the thyroid cancer. To prevent this, a higher dose of thyroxine has to be given, and this is known as the suppression therapy. Okay, TSH suppression therapy. Under normal circumstances, the hypothalamus releases the TRH, which stimulates the anterior pituitary gland to release the thyroid stimulating hormone or the TSH, which then stimulates the thyroid gland to release its hormones, the thyroid hormones T3 and T4. Okay, this in turn, T3 and T4, have a negative feedback mechanism on the pituitary as well as the hypothalamus, thereby reducing the release of TRH and TSH. This negative feedback mechanism helps to keep the various hormones TRH, TSH, and T3 and T4 in equilibrium and balance. The next consideration is the treatment of thyroid cancer using thyroid hormone suppression methods. After thyroidectomy, all patients will require some form of thyroxine therapy, either replacement or suppression. Replacement when there's no more thyroid tissue left, and suppression is to suppress the TH stimulation of the thyroid. Using dose of levothyroxine to suppress the TSH may minimize the potential thyroid cancer growth or recurrence. For patients at low risk of recurrence, attempt to maintain the TSH between 0.1 and 0.5 micro units per liter is advisable. For patients at higher risk, attempt to maintain the TSH less than 0.1 micro unit per liter. In summary, thyroid suppression is used after thyroidectomy and radioablation of the thyroid gland. Reduces the tumoral growth and recurrence rates after surgery or after radioablation. Suppressive dose of thyroxine is 0.3 milligrams daily for lifelong. And the TSH levels should be less than 0.1 microunits per liter. Coming to prognosis, three important factors must be taken into consideration. Most thyroid cancers are very curable as compared to other cancers. That is the number one consideration. Secondly, the most common types of thyroid cancer, that is the papillary and follicular, are the most curable among the cancers. Okay? And thirdly, in younger patients, especially those less than 50 years of age, both papillary and follicular cancers have a more than 98% cure rate if treated appropriately. So, it is very important to detect the patient early and treat them aggressively so that you can get a cure of 98%. If you're talking of cure rate, not 5-year survival rate. In fact, for papillary tumors, we can talk of cure rate, not 5-year survival rate. So it is a curable condition which must be treated aggressively. Okay, this slide shows you the prognosis, the survival rate of the various cancers of the thyroid. Papillary, being the most predominant of the thyroid cancers, has a 10-year survival rate of 74 to 93%. In fact, some authors today quote as high as 98% 10-year survival rate. In fact, many of us are talking about cure rather than survival rate. Follicular carcinoma, which consists of about 10% of thyroid cancers, has a 10-year survival rate of 43 to 94%. Its Hertel cell variant, which constitutes about 4% of the thyroid cancers, has a 10-year survival rate around 76%. The undifferentiated anaplastic cancers, which constitute less than 2% of thyroid cancers, are the most aggressive and rapidly invasive of the tumors of the thyroid gland. It has a median survival rate of 4 to 5 months from the time of diagnosis. There are some special features of thyroid cancers as compared to the traditional overview of cancers. Thyroid cancers affect the young patients. Most of the patients are around 30, average of around 30 years of age. The tumors, especially the differentiated thyroid tumors, are slow growing tumors, and they rarely or very slow to metastasis. And there are a lot of them with asymptomatic occult metastasis, which may be insignificant. Thyroid cancers are also easily diagnosed with FNAC, and there is effective and simple treatment available to control the disease. And because of all this, there is a very good prognosis for thyroid cancers. In fact, for the differentiated thyroid tumors, we are thinking of cure, not survival rate. So considering all these factors, the traditional concept was early aggressive treatment for all thyroid cancers with total thyroidectomy and cervical lymph node clearance. However, of late there has been some new trends on the treatment of thyroid cancers. Because of the special features which I mentioned, we tend to classify the patients into risk categories, especially the differentiated thyroid cancers, papillary and follicular. You classify them according to low risk, according to the size of the tumor, which is less than 1 centimeter or less than 10 millimeters, localized to the thyroid and intracapsular. The second group will be the high risk group, which has the size of tumor more than 1 centimeters, or it can be multifocal and even extracapsular. So the new concept is more conservative treatment of the low risk cases, so as to avoid radical treatment for those who do not need it. High risk patients must be aggressively treated with all the available methods: surgery, radioiodine ablation, and TSA suppression. I hope my short presentation today will be of some benefit to you. Hope to see you again in another session in the near future. Thank you.